and the next presentation will be by Dr. Antman, my co-chair. It's going to be on a clinical approach to management. While Dr. Antman is taking the stage, I would like to say again that we in the Israeli Heart Society are very excited to have for the first time this combined session in Israel with the American Heart Association. We are really convinced that that's the beginning of a collaboration that will prove up to be a continuous collaboration. And we thank you, Elliott, for all your support. Thanks a lot.
Thank you very much, Yossi, and it's indeed a great pleasure to be here again and to participate in this session. Armed with the information that Dr. Chaim just showed us about the epidemiology of atrial fibrillation, we can now think through our clinical approach to management. And I think as we'll walk through this, we'll see that there are some things where we don't quite have it right, and we will need to look into the registries and databases and actually perform some additional clinical trials. I am an investigator in the TIMI study group, and here is the list of disclosures for all the sponsors for the TIMI study group over the last 20 or 30 years. Those where I was the principal investigator are highlighted in yellow. So atrial fibrillation surely is a global problem. The data that you saw from Israel are a segment of the data that really we need to be aware of on a worldwide basis. There are 33.5 million individuals around the world who have the problem of atrial fibrillation, and as you saw, it is a disease state that we see much more commonly as a person ages, and with the success that we've all had in our treatments for patients, our population is aging, so this is going to be a problem that we're going to all have to deal with more and more in the future. It is associated with a very high cost to our medical care system. And in particular, when an individual has a stroke, the cost of caring for that individual at the time of their acute care and their long-term rehabilitation and follow-up care is what is an important driver of that cost. So as we think about the 5 steps to management of atrial fibrillation that I will present to you, let's think about first the fact that we have to know that our patient has atrial fibrillation. And of course, the way we make that diagnosis is by an electrical recording. Now, this slide shows you some of the traditional ways that we have done this on the top, which of course is our 12-lead electrocardiogram, the Holter monitor, and an event monitor. Let us not forget that we have available to us now implantable loop recorders, such as at the bottom left. Let us not forget that there are individuals who, for one reason or another, may have a permanent pacemaker, and we can take a recording off the right atrial lead. I have personally been very impressed with the device exemplified on the bottom right. This is a case that fits on the back of a smartphone, and it has 2 metal plates on it. A number of companies make a device like this, and by actually just holding the smartphone with your fingertips on that metal plate, you can actually record a lead 1 rhythm strip, and I have actually been able to diagnose atrial fibrillation in my patients this way quite successfully. There are some interesting studies about this, a number of them, for example, in Sydney, Australia, that actually performed a surveillance study to see whether or not individuals who came in to have their prescription, let us say, filled for antihypertensive medications, routinely had a recording like this, and they picked up an incidence of about 1.5% undiagnosed atrial fibrillation. And if you think about the risks over time of a stroke, this is an important potential surveillance technique that we should be considering. And here's the pattern of atrial fibrillation. This is from our guidelines, and it talks about defining the atrial fibrillation pattern. In the middle left, we see paroxysmal, where the arrhythmia terminates spontaneously, persistent, where it is sustained beyond 7 days, and then permanent, where cardioversion has failed or has been foregone because we wish to keep the patient in atrial fibrillation and appropriately anticoagulate them. One might ask whether or not we actually have to go through all this exercise of actually defining the subtype of atrial fibrillation. I don't think we're there yet in terms of our ability to say whether we should or shouldn't do that. But as you saw from the data that Dr. Hayam presented to you, clinicians are acting on this information with the belief that individuals who have persistent or permanent atrial fibrillation are more at risk of a cerebral embolism. But interestingly, the data from the Euroheart surveys that have been performed actually raise concerns about paroxysmal atrial fibrillation having a nearly similar rate of risk of cerebral embolism, and therefore paroxysmal atrial fibrillation has been included in non-valvular atrial fibrillation for consideration of anticoagulation. Now, this is an interesting point. The general cardiology evaluation, of course, includes taking the clinical history and performing the physical exam, looking for any associated disease, the cardiac and extracardiac disorders that we might be interested in uncovering. Sleep apnea, hyperthyroidism, and heart failure are certainly high on our list of things that we would search for. The imaging investigations haven't changed for decades. A transthoracic echo or transesophageal echo may be an electrophysiology study. And here we're looking at cardiac structure and function, atrial size. We're looking for the evidence of a left atrial clot, especially if we're going to be performing a cardioversion. I would call your attention to the fact that there are many modern imaging techniques, for example, MRI imaging, and that is particularly why Dr. Jeffrey Goldberg is going to be talking about MRI imaging in atrial fibrillation later in this session to see how we could incorporate some of our newer imaging techniques into this general cardiology evaluation. Rhythm monitoring, of course, is predominantly for paroxysmal atrial fibrillation, looking for the frequency of AF. Let me remind you that the same device that I showed you that clips onto the smartphone can actually be used for assessing paroxysms of atrial fibrillation. I have many patients who have palpitations, and we're trying to determine exactly what it's due to or how frequently they're having their episodes of atrial fibrillation. They simply carry that little case with them, and they can record a rhythm strip for us while they're having their palpitations. I use a stress test here for assessing ventricular rate control. As you know, a person can appear to have perfectly well-controlled ventricular rate and atrial fibrillation at rest on an examining table, but performing some kind of exercise evaluation is extremely important for ascertaining their response to medication. This is perhaps the thing that's occupied most of our attention, which is to assess the need for and then to select the oral anticoagulant once we've made the decision that the patient needs an oral anticoagulant. And yes, we have these traditional risk scores, which are the CHADS-2 risk score, and then as you saw, the CHADS-2 VASC risk score is available to us. And it has been argued that the CHADS-2 VASC score gives us better fidelity at the lower range, and we can find individuals who might have a disturbing risk of embolism that we wouldn't have picked up if we had just used the CHADS-2 score, and we can identify individuals who might be at greater risk. I completely agree that this is the first step in our journey of trying to figure out how we should identify patients who need anticoagulation in atrial fibrillation, but it's not enough. And here's a very simple bit of information. Suppose you were to encounter a person who had atrial fibrillation and you've made a decision based upon this, but you ought to be asking a question, has this individual ever had a vitamin K antagonist in the past, especially if they had previously been treated for atrial fibrillation? It's a problem they've had many years ago. Now they're coming to you again with atrial fibrillation. So we had the opportunity to examine this in our study of about 21,000 individuals with non-valvular atrial fibrillation. This was the ENGAGE AF TIMI 48 study. Many individuals were enrolled here in Israel. And we had about 40% of individuals who were VKA naive. They're shown on the left. and on the right, those individuals who had prior vitamin K antagonist exposure. So the first thing you can see, before I tell you what each of the curves represents, is that the proportion of individuals over the nearly 3-year follow-up in this study who had a stroke or systemic embolic event was generally lower if they had prior VKA exposure. Now that makes sense because they've selected themselves as an individual who actually had survived long enough to actually come to us with non-valvular atrial fibrillation, and they've also survived previous treatment with a vitamin K antagonist. Now, our study actually had as the control group our standard of care, which is warfarin, and then we examined 2 different doses of one of the new oral anticoagulants, edoxaban. And so what you see here in the red curve on the left is the Kaplan-Meier curve for warfarin-treated patients who were VKA naive, and we had a low dose of edoxaban, which looked very similar to warfarin with respect to the chance of developing a stroke or systemic embolic event. These individuals, however, had a much lower risk of bleeding. Those individuals who had a higher dose of edoxaban actually had a substantially reduced risk of stroke or systemic embolic event if they had never seen a vitamin K antagonist previously. On the right-hand side, we see individuals who had previously been treated with a vitamin K antagonist, almost always for atrial fibrillation. And you can see the warfarin curve there. Just compare the 2 red curves. It's much lower in individuals who had actually already been exposed to warfarin. And here our low-dose edoxaban was simply too low. This is a valuable piece of information for us. And here our high-dose edoxaban operated almost therapeutically interchangeable with warfarin with respect to efficacy, but the bleeding rates were lower. So in addition to that original CHADS-2 or CHADS-2 VASC score, one of the questions that I now think through with my patient is whether or not they've previously been on a vitamin K antagonist, because if they have not, then this is an individual who I think is going to be a particularly good candidate for some of our new oral anticoagulants, as shown on the left. So what do we want when we consider an antithrombotic treatment regimen in patients with atrial fibrillation? So surely we have our patient with AFib, and we want to prevent an ischemic stroke, reading across the top row now. We would like to do so without exposing the patient to the risk of a hemorrhagic stroke. Although it's much less frequent, we don't want our patient to have a systemic embolism. When these embolic events occur to the gut or to the limbs, there can be some very serious consequences to the patient. And of course, all of us, when we prescribe a medication, don't want to create a problem. We don't want our patient to be exposed to bleeding risk. We don't want to have to transfuse the patient, and we certainly do not want our patient to experience a bleed which results in their death. When we use these new agents, it would be convenient for us and certainly for our patients if there was no need for therapeutic drug monitoring. We would like to have few food and drug interactions so that we don't have to worry as much about adjusting the dose of the oral anticoagulants, something that we have to do quite frequently, as you know, with a vitamin K antagonist. Although it is infrequent that we will have the need to reverse our agent, that's always on our minds. What is the reversal mechanism that we could consider, particularly for some of the new oral anticoagulants? And we want to be attentive to transitions. Let's be mindful of the pharmacology here. You are aware of the fact that a vitamin K antagonist works by decreasing the active form of vitamin K dependent factors 2, 7, 9, and 10. The half-lives of those factors are measured in the order of days. So missing one dose of a vitamin K antagonist is not going to necessarily have terrible consequences for the patient within the next day or two, as long as they continue to pick up their dosing within the next day after they've missed it. All of the new oral anticoagulants have much shorter half-lives. They're usually given once a day, in some cases twice a day, and if you miss 2 doses, you are almost back to an unanticoagulated state. This is extremely important when thinking about compliance with the medical regimen. We had the opportunity to summarize the data on all the new oral anticoagulants when we reported our edoxaban study, which is ENGAGE-AF TIMI-48. It was the fourth of the new oral anticoagulants that were reported. And this is the grand total experience now in about 72,000 individuals. So with respect to ischemic strokes, this is extremely important. Many of the papers that you see in the literature combine ischemic and hemorrhagic stroke, and you see total stroke. And that's the primary endpoint. But if you actually look at the types of stroke, the ability to prevent an ischemic stroke is very similar with the new oral anticoagulants. The real advance with these new drugs is the 50% reduction compared to warfarin with respect to the risk of a hemorrhagic stroke. Major bleeding is reduced by 14%, except for GI bleeding. That's up by 25%, relatively infrequent, but it is higher with the new oral anticoagulants. So let's put that on our checklist of things that we don't understand about the bleeding risk in the brain versus the gut. And we need to work that out, and that's still an open area for investigation. One of the attractive aspects of the new oral anticoagulants is the fact that we don't need to use laboratory monitoring. There's been lots of discussion about whether or not we need to use pharmacogenetics when we prescribe a vitamin K antagonist. That absolutely does not need to be done for individuals getting a new oral anticoagulant. We've had some papers published recently in Lancet looking at this, and this does not appear to be a requirement for prescribing new oral anticoagulants. There are antidotes that are under development. Right now, if you needed to reverse a new oral anticoagulant, you could give prothrombin complex concentrate, which is available in most blood banks, hematology labs, and I know you have very sophisticated blood banks here in Israel. I'll remind you that these new drugs have a short half-life, typically 8 to 12 hours, so transitions, a person coming in to actually have an orthopedic surgery, going for a colonoscopy, that's a transition period where you have to be worried about the risk of developing an embolic event, compliance with the regimen. So when you have that conversation with your patient now, remind them that this is a pill that they have to have a reliable system for taking, because if they skip a day or two, they're traveling, they forgot to take their medication with them, they are no longer anticoagulated. That is a very big difference compared to warfarin. This very dramatic reduction in hemorrhagic stroke and the risk of overall major bleeding does carry with it the responsibility of a special attention to compliance with the regimen. Now let's think about how we would decide how much to give to a patient. Some of the trials that actually reported data on the new oral anticoagulants reported the results with just a single dose. Some looked at more than one dose, typically a high dose and a lower dose. All of the studies were attempting to inhibit a critical point in the coagulation cascade. In this example, we were inhibiting factor Xa, and you can see a X-ray crystallography structure on the top left of this diagram, and right in the catalytic center happens to be the new oral anticoagulant. In this instance, it's edoxaban sitting in the catalytic center. It could be factor 2A, and it could be dabigatran sitting there. So we want to know how much inhibition of factor Xa in this instance is taking place. That's a much more complicated assay than to simply measure the concentration of edoxaban or the new oral anticoagulant. So as a surrogate for the inhibition of the critical point in the coagulation cascade, we measure the blood concentration because there is a tight one-to-one relationship between the blood concentration of the new agent and its ability to block that critical catalytic center. So what you have here is the probability of an event occurring over the 3 years of the study with low-dose edoxaban where there was no need for dose reduction, low-dose edoxaban where there was need for dose reduction. So you have dose reduction is the first blue line on the left, then there is no dose reduction. Then we have the high dose of edoxaban, which was about double the dose compared to the low dose and there was dose reduction required because of a variation in renal function, a drop in creatinine clearance, and high-dose edoxaban with no dose reduction. And just as you would imagine, there were different concentrations of edoxaban that these 4 approaches yielded. And there were therefore different degrees of inhibition of factor Xa. Just exactly what you'd expect. If you just look at now the blue curve for stroke or systemic embolic events, the higher the concentration of the new oral anticoagulant, the more inhibition of the catalytic center of the critical element of the coagulation cascade, and therefore the lower the risk of stroke or systemic embolic events. All this occurs at the risk of an increase in major bleed, but remember that the overall chance of a major bleed was reduced compared to warfarin. Second item for our checklist of things we don't understand is why that relationship is flat for intracranial hemorrhage. It didn't seem to matter because the risk of intracranial hemorrhage was at the same low background level, but it did not vary with the dose regimen that we were using. So we don't understand why intracranial hemorrhage occurs despite the varying dose regimens that we're talking about, whether it was low dose with dose reduction or high dose without dose reduction. Some have argued that by leaving tissue factor unblocked in the cerebral vasculature, that we may be putting the patient overall at risk for intracranial hemorrhage with a different relationship than is seen with warfarin. It is postulated with warfarin that the higher the INR, the higher the risk of intracranial hemorrhage. Does not appear to be the case here with the new oral anticoagulants. There is hope on the horizon for specific reversing agents. So here's a model on the left of factor Xa. This is a ribbon model. And then the diagram that I've shown you previously is the X-ray crystallography structure of it. Now, how might you do this? So there are a number of possibilities. One is to actually have a monoclonal antibody, which is being developed by one of the pharmaceutical agents, and idaruximab is a humanized monoclonal antibody that is directed against the oral anticoagulants, the new oral anticoagulant. In this instance, it was made up for inhibiting dabigatran's effect on 2A. The bottom right shows you a small molecule made by a biotech startup company, very much like what Dr. Strauss talked about earlier today about innovation. This is a biotech startup company that was inspired to come up with a small molecule, an oral agent that could actually reverse a number of the anticoagulants that we use. And this is in clinical trials right now, and hopefully will be fast-tracked by regulatory authorities because we need to have an agent like this. A completely different approach is to actually make a factor Xa decoy, which is what is being made here in San Francisco with adenexant alpha. And the notion here is very much like we use the digibind agent to actually block, to actually adhere to digitalis molecules more avidly than to the alpha subunit of the sodium ATP component of on the cell membrane. This new agent, which is under development, will actually bind more avidly to the new oral anticoagulant, thus shifting the equilibrium so that it comes off the catalytic center of factor Xa in this instance, making factor Xa available again to promote coagulation. So these are things that I would recommend that we keep our eye on in the future. The last step, of course, is to pick the management strategy that we're going to deal with. And the two ones that are well known to this audience are rhythm control and rate control. So rhythm control is something that we thought was what we needed to do a lot more of, and that's when we would cardiovert patients, our antiarrhythmic therapy, and we learned time and time again the painful experience of the risks of antiarrhythmic therapy. However, ablation is something that we ought to be talking about and thinking about whether or not we can actually afford our patients better exercise capacity, possibly the elimination of the long-term need for anticoagulation. But I've put a question mark there because we don't have 100% effectiveness of ablation procedures, and there's a possible late risk of recurrence and therefore the need for anticoagulation. More and more patients are left in atrial fibrillation. Their ventricular rate is controlled with a combination of rate-slowing agents. What we now know is that if you can achieve optimum rate control, you get the same quality of life, similar rates of stroke, and no difference in mortality. And one of the things that we have to think about is the natural history of atrial fibrillation. And this, I think, is a very important piece of information for us. As I began studying some of the new antiarrhythmic agents for atrial fibrillation, I began to observe, and I'm sure like many of you have, that individuals who first presented with paroxysmal atrial fibrillation over 5 to 10 years would more and more frequently have episodes and would eventually have permanent atrial fibrillation. And so this is a classical diagram. I think this one comes from the European authors, showing the natural time course of atrial fibrillation with an individual presenting with paroxysms, frequent episodes of cardioversion, and eventually the decision is made to leave this patient permanently in atrial fibrillation. Now, the playing field just got very complicated right under our feet. So here's our patient with atrial fibrillation. And we, the physicians caring for this patient, as shown by the little image on the left, focus so much on stent thrombosis when we put in a stent in a patient. We heard about that earlier today as well. The ischemic events and stroke risk. Our patients certainly don't want to have those things happen, but they get very concerned about the risk of bleeding. So here's the combination of the patient and the physician now talking about the risk of bleeding, and it just shifted because now we have dual antiplatelet therapy, and the data that were presented at the American Heart Association scientific sessions in November, the very large dual antiplatelet therapy trial suggests that it may be beneficial to our patients with drug-eluting stents, in particular, that dual antiplatelet therapy beyond 1 year would be particularly helpful. This is all happening while we have newer stents, some of which are bioabsorbable, and we don't really know what the risk is going to be in terms of stent thrombosis developing there. And of course, we have to weigh all the information about a new oral anticoagulants versus vitamin K antagonists. But there is hope. There is a way that we can get to the bottom of this because we are in an era where we can deal with big data. And we actually need to combine some of the information from the various trials. And 1 year ago, I talked about this when I was privileged to give the Neufeld lecture here and proposed that we ought to be thinking more about a personalized management of atrial fibrillation. So let's think about taking all the information we get from a patient's clinical presentation, the data from their electrocardiogram, their pattern, the biomarkers, all the imaging procedures that we know of now and that we're going to have available in the future, feed this information into a network so that we can actually think about whether the patient has a simpler form of atrial fibrillation. There might be a monogenic cause, it might be focal, it might be something we see in a post-operative patient. Or is this a complex situation where the patient might have valvular disease, they are elderly, there's a polygenic cause, or they may be unclassified at the moment. This is how we're going to be more precise and give more personalized attention to our patients. And at that point, we will be able to have a talk about the management of atrial fibrillation and with greater precision be able to say who truly would benefit from our attempts at rhythm control, what form of anticoagulation would be optimal for the particular profile of patients, and how should we think about treating concomitant diseases so as to minimize the risk for atrial fibrillation in the future. Thank you very much for your attention.